I wish to thank the organizational committee for their kind invitation to speak at this prestigious Congress in Tehran. I am very displeased not to be present in this Congress. It is only an online lecture, so we can start. The first fundamental issue to address in order to fully understand my daily lecture is why marginal bone stability is so important. I shall now explain. Fundamental requisites for implant success are: first, good and possibly fast osseointegration. Good meaning high bone implant contact. And second, marginal bone stability over time, that meaning bone level maintenance over the long term. However, recent systematic reviews reveal a significant prevalence of perimplantitis for both patient and implant level. Perimplantitis represents a problem in terms of prevalence, but most of all in terms of treatment efficacy. In fact, for example, in this recent randomized clinical trial, using a traditional surgical treatment, perimplantitis therapy success was obtained in only 45% of all implants treated, less than 50%. And the authors concluded that perimplantitis prevention is more predictable than perimplantitis treatment. For this reason, we should focus on marginal bone stability and its measurements. Marginal bone loss was first described by Adele, who calculated a very generous 1.5 millimeters after the first year of implant loading, as seen in this sequence, where bone level remains very stable over the long term, despite the worsening oral and general health condition of this old patient. This criteria defining implant success has also been maintained by Arbregson. Up to 2 millimeters after the first year of loading, then between 0.1 and 0.2 millimeters annually thereafter. But is this criteria still usable, still credible? Probably not. The retrospective study by Galindo Moreno showed that early marginal bone loss at 6 months is an indicator of bone loss progression over time. Specifically, implants with early marginal bone loss greater than 0.44 millimeters at 6 months. From a clinical point of view, this means 0.5 millimeters at 6 months, lead to marginal bone loss greater than 2 millimeters at 18 months in 97% of these implants, the implants of this first group. But what is the limit of this study? This is a short-term 18-month evaluation. A comprehensive 10-year evaluation is presented in this prospective study, where more than 1,400 implants were followed up to 10 years. The perimplantitis rate was approximately 12%, in agreement with previous systematic reviews, but very significant is the correlation between early peri-implant marginal bone loss and perimplantitis. Implants with early marginal bone loss greater than or equal to 0.5 millimeters during the first year of loading demonstrated a 5 times higher probability of future perimplantitis. Additionally, the more this MBL threshold is exceeded, for example, 1 millimeter rather than 0.7 millimeters, the lower the implant survival rate and the greater the risk of perimplantitis. Therefore, the risk threshold for perimplantitis is 0.5 millimeters. Keep this in mind and take an X-ray after 6 or 12 months of loading in order to prevent perimplantitis. And what does this 0.5 millimeters mean? Marginal bone loss greater than 0.5 millimeters represents an unwanted exposure of rough implant surface to the bacteria of the oral cavity. Surface roughness determines biofilm formation by facilitating biofilm adhesion, maturation, and colonization. In this environment, in the peri-implant sulcus, perimplantitis can start. And you can see some risk factors for perimplantitis. Some of them are well-known systemic factors like history of periodontitis, smoking habits. Others are well-known local factors, the absence of keratinized mucosa, a poor prosthetic design. But I want to underline the other local factor, exposed micro-rough implant surface to the bacteria of the oral cavity. This kind of surface can represent a risk factor for perimplantitis. Keep this in mind over the course of my lecture. Exposed micro-rough implant surface. And what is the etiology of marginal bone loss? The etiologies of marginal bone loss are still unknown. The most convincing hypotheses are included in this color-coded table. So we should focus on specific strategies for preventing or minimizing MBL during implant therapy, including the surgical protocol, implant design, prosthetic protocols, and host-related factors. Starting from surgical protocol, I shall focus on ideal three-dimensional implant placement, which can limit marginal bone loss. This decision tree synthesizes very well ideal three-dimensional implant placement, especially emphasizing the slightly palatal position of the fixture in order to minimize horizontal buccal bone resorption and maintain at least 2 millimeters of facial bone thickness. Marginal bone loss is not a vertical bidimensional phenomenon with only mesial and distal measurements, but a fully three-dimensional phenomenon, which determines circumferential cratering around the implant neck. This horizontal distance between implant platform and the bone crest is approximately 1.3 millimeters. And now, in this drawing, you can understand the importance of 2 millimeters of facial bone thickness. 2 millimeters of facial bone thickness permits to maintain a peak of bone buccally in order to avoid the exposure of the titanium in aesthetic areas. And let's see our decision tree. The first step, the first position is the bucco-palatal position. We will analyze both in aesthetic areas and in posterior areas. in aesthetic areas, at least 2 millimeters are required, of course. In absence of this thickness, a GBR, an horizontal GBR procedure is recommended. However, in posterior areas, at least 1 millimeter of buccal bone thickness is required around the implant neck. The consequent question becomes what is the appropriate, the sufficient alveolar ridge width for a correct three-dimensional buccopalatal position of our implant, the standard implant of 4 millimeters of diameter. You can see this situation. We can calculate at least 2 millimeters of facial bone thickness. Then the implant diameter, a standard implant diameter, 4 millimeters. Then at least 1 or 2 millimeters of lingual thickness. So the solution of this problem is at least 7 millimeters of alveolar ridge width for a correct buccopalatal position of our fixture. And which is, in this condition, the first step that the surgeon must move. The surgeon must must mark with the first drill the ridge, adopting the 4 millimeter rule. Why the 4 millimeter rule? Because with our drill, I can mark the drill 4 millimeters from the vestibular edge, the vestibular margin of the crest, in order to create in this area the bone site, a bone site of approximately 4 millimeters of diameter. And we can maintain 2 millimeters of facial bone thickness plus 2 millimeters of, which represents half of implant diameter. This is the 4 millimeter rule for a correct position, especially in aesthetic areas. Then, if the alveolar ridge width is insufficient, for example, we have 6 millimeters of alveolar ridge width, which is our behavior. In this situation, we can utilize, of course, a narrow implant for a lateral incisor, for example, but we have only approximately 1 millimeter of buccal bone thickness. In this situation, I suggest a connective tissue graft in order to prevent an aesthetic failure, for example, a shadow of the titanium throughout the soft tissue and the bone. And if the alveolar ridge width is 5 millimeters or less, we can utilize a GBR procedure and eventually a connective tissue graft in order to recreate 2 millimeters of facial bone thickness. Of course, we can have dehiscence or fenestrations. And it is very important to distinguish not the issues from fenestrations, but the predictability of these bone defects is determined by the morphology. If we have a class 1, a housing bone defect, rather than a class 2, a non-housing bone defect, of course, we have a better predictability of our horizontal regeneration. In this situation, for example, I have performed an horizontal regeneration. This appropriate facial bone thickness limits circumferential cratering around the implant neck in order to avoid a buccal bone recession, which represents a failure in this area. In these two different clinical cases, however, critical bone dimensions were not respected, with subsequent complications, aesthetic and functional complications, not a perimplantitis, but only the absence of keratinized mucosa for poor oral hygiene, for example. Other situation. In this situation, you see the implant, the bone, the alveolar bone width is sufficient, is appropriate. Probably 7 millimeters are present, but the implant was placed in a wrong, very wrong position, an incorrect position of the long axis of this implant. You see that a very thin bone, buccal bone is present, less than 1 millimeter. However, the implant diameter is approximately 4 millimeters, and 3 millimeters of palatal bone thickness are present. But in this situation, we have to remove this implant. We have to remove it. Another clinical case, hopeless left central incisor was substituted with an implant. The correct three-dimensional implant position permits to obtain a good emergence profile, a good papillae height, and a pleasing aesthetic outcome. Second step, the mesiodistal position of our implants. The distinction is between aesthetic areas and posterior areas, but for both situations, for both areas, a common rule is the following. At least 3 millimeters of bone are required between adjacent implants. If we place adjacent implants in aesthetic and posterior areas, we must guarantee at least 3 millimeters of bone. Then, in aesthetic areas, if the implant is in a narrow is placed in a narrow space, in a narrow area, such as a lateral incisor, the rule is at least 1.5 millimeters, the space from the implant to the adjacent tooth. This is the minimum space, 1.5 millimeters, for the periodontal ligament of the adjacent tooth. The vascularization of the papilla is fundamental, and the ligament is fundamental too for this. At least 1.5 millimeters from the implant to the adjacent teeth, the space. And what is the vertical potential growth of papilla, of interproximal papilla between implant and adjacent tooth? All the historical studies by Theran and Salama demonstrated that the potential vertical growth of papilla, interproximal papilla between implant and adjacent tooth, is approximately 5 millimeters. Calculated from the bone crest of the adjacent tooth to the contact point of the crowns. If this distance becomes greater than 5 millimeters, the predictability of papilla is inferior, is not guaranteed. The greater the distance, the greater the unpredictability of papilla growth. And you can see these rules. If we obtain an optimal result of a complete papilla growth, if the distance is between 4 and 5 millimeters from the adjacent tooth to the contact point of the crowns. If this distance becomes between 5 and 7 millimeters, we have an unfavorable result. We can speak of unpredictable result. It is better. If this distance becomes greater than 7 millimeters, of course, a severe result means a failure, not a complete papilla growth. Papilla growth becomes less predictable in presence of 7 millimeters of distance or more, of course. Three different situations. An implant placed in a static area, central incisor, the distance is 4 millimeters. Okay, 100% of papilla growth. It is very predictable, the papilla growth. Second situation, 5 millimeters, the distance from the bone crest to the contact point. We have a very high predictability. However, in this third situation, of course, it is rare to find a complete papilla filling. And the subsequent question becomes, how long does it take to grow for the papilla? The answer in this study by Scrop, you can see, in approximately 18 months. In approximately 18 months, less than 24 months. Of course, it depends on the phenotype, thick phenotype rather than a thin phenotype, and also the kind of prosthesis utilized in this situation in order to condition the soft tissue. Another step, the mesiodistal distance in posterior areas, of course. Between two adjacent implants, we have spoken of at least 3 millimeters of bone, of course, but if there is an identical space, as you see in this picture, the canine is a natural tooth, then two different implants. What is the rule? This is the rule between the natural tooth and the first implant. It is possible, if possible, 5 millimeters. Because 5 millimeters? Because we have in this situation 3 millimeters of bone and the ligament, of course, of the canine, and 2 millimeters represents half of the implant diameter. 3 plus 2 millimeters, 5 millimeters. With the first drill, we must mark the alveolar ridge in this situation for a good papilla growth. And the distance between two adjacent implants, of course, is at least 7 millimeters, because we have to calculate the same rule, 2 millimeters of half of the diameter of the implant plus 3 millimeters of bone, and again 2 millimeters of half of diameter of the second implant, between 7 and 9 millimeters. Why 7? Between 7 and 9. 7 is the minimum space. 9 represents a good space in presence of wide diameter implants. And this is a clinical case explicative of this situation. You find a complete papilla of 5 millimeters in height between two natural teeth, the lateral incisor and the canine, natural teeth. A papilla of 4.5 millimeters between natural tooth and the first implant, you see. And however, a papilla of only 3.5 millimeters between the two implants, when we are fortunate, because we have this kind of a papilla between implants, because we have no periodontal ligament, no blood supply from this area. This is the reason for which the papilla growth between two adjacent implants is diluted normally. And this is the final outcome of respecting these rules. In our decision tree, again, the third dimension is the epicocoronal position of implant platform. Again, in aesthetic areas, normally between 3 and 4 millimeters are required below the cement enamel junction and our implant platform. As seen in this first picture on the right, you see the implant platform was placed correctly in the bone approximately 4 millimeters from the cement enamel junction of the two adjacent teeth. However, second situation, in the middle picture, we have approximately the same space, the same distance. The implant platform can be placed correctly also in this second situation. Probably an horizontal augmentation is required with a connective tissue graft. However, in the third situation on the left, you see a completely different bone defect. Placing implant platform in the correct position, epicoronal position, we have to regenerate approximately between 8 and 10 millimeters. So a vertical GBR procedure is required, a procedure fundamental in aesthetic areas, but not so predictable than an horizontal augmentation. Of course, in posterior areas, the situation is completely different. Normally, very invasive treatment, vertical GBR positions are not required, are not accepted by our patients. So we can place short implants. And in the second part of my lecture, at the end of my lecture, after a long process of comprehension of the prosthetic protocols, I shall show you the adaptation of implant position to mucosal thickness. Another concept, a new concept to complete this three-dimensional implant position of our implants. Let's see the surgical protocol. If bone temperature exceeds 53 degrees centigrade, irreversible tissue damage occurs. Therefore, 47 degrees for 1 minute is the border condition for injury. In this situation, we can determine a bone necrosis, an apical bone necrosis, as you see in this implant. Second aspect, what determines excessive cortical compression during our surgical protocol? High insertion torque, greater than 30 Newton centimeters, increases critical pressure, triggering microfractures and bone necrosis, determining bone resorption in the cortical bone. And what about implant abutment connection disconnections? We know that a micro gap does exist between abutment and implant. Inflammatory substances and bacteria are present in this space, as you can see in this second image, which is simply the magnification of the first. You can understand, you must know, the clinician must know, that micro gap dimensions are greater in external X connections and smaller in internal connections. Therefore, the consequence is that crestal bone levels are better maintained when internal connections are utilized. Therefore, the clinician should adopt the first implant on the left with an internal connection rather than the second with an external connection. And in presence of multiple implants splinted under the same screw-retained fixed prosthesis, internal connection is not indicated. For this reason, we can use multi-unit abutments more, and in this situation, internal connection is transformed into supracrestal external connection. The microgap is present, but is far from the crestal bone. This is fundamental, of course. An additional consideration: platform switching design helps to prevent peri-implant marginal bone loss with all connection types. And implant abutment mismatch greater than 0.4 millimeters is associated with a more favorable bone response due to this mismatch increasing the distance between the microgap and the bone crest. And the tissue-level implants represent an interesting alternative to bypass the microgap issues. Let's see the X-ray. The microgap is located above the bone crest, far from the bone crest. And what about crest module design? Concave and convergent implant transmucosal profiles result in less MBL than parallel or divergent profiles. These former are more appropriate than the latter to avoid compression of hard and soft tissue. And what about crest module surface treatment? So we can speak of implant collar surface treatment. A premise is very important premise, and classification is required. This historical classification by Arbegson, we can identify the so-called polished surfaces, very smooth surface, but osseointegration does not occur around these kind of surfaces, polished. A minimally rough surfaces are the machine surfaces, the second, with a roughness between 0.5 and 1 micron. Then we identify the so-called moderately rough surfaces, etched and sanded blasted implants, and the last are the rough surfaces. Why this premise? Because we know that moderately rough surfaces seem to prevent MBL when compared to minimally rough surfaces. In the implant collar in this area, however, new generation hybrid implants could reduce the risk of periimplantitis over the medium to long term due to their specific coronal machine surface characteristics. Paradoxically, both these implants are hybrid due to the presence of a machined surface in the coronal portion of the implant. 1/3 of the length for the first implant, on the left, this one, and only the collar for the second, but both are hybrid implants. I prefer to use the first hybrid with 1/3 of machined surface in patients with severe periodontal disease, and all other clinical cases, in all other clinical cases, I utilize this second implant. We know that machined surface charged energy more than its roughness greatly decrease bacterial adhesion, reducing the risk of periimplantitis. Additionally, the machined surface promotes a better adhesion of epithelial cells and hemidesmosomes compared to rough surfaces. On the other hand, however, around machined surfaces, osseointegration occurs slower, but it occurs. And this is a fundamental concept because you must keep this concept in mind when we speak later of subcrestal implant placement. We can place a machined surface, a collar implant, below the bone crest. Machined but not polished. This is the concept. And for this reason, I should now investigate how our restorative protocols can influence biologic width establishment and consequently crestal bone remodeling around implants. Recent findings suggest that early peri-implant marginal bone changes are time-related during the first year of loading. Specifically, in the graph, you see MBL variations around bone-level implants at 3 different time points: at T1, at the reopening appointment; at T2, after 6 months of loading; and at T3, after 1 year of implant loading. The major component of marginal bone loss occurs immediately after the second surgery and the subsequent abutment connection. Thus, it is evident that marginal bone loss around bone-level implants is more correlated with the prosthetic phase than with the posturgical phase. And we can correlate some of the most important etiologic factors with these temporal phases for a better comprehension of the phenomenon. And you can observe, for example, that after the second surgery, marginal bone loss can be determined by prosthetic variables, such as implant abutment connection disconnections, the presence of the micro gap, and the biologic width establishment following the final abutment connection. However, bacterial infections can determine progressive bone loss over the longer term. Poor oral hygiene, smoking habits, and history of periodontitis can influence this last phase. And around the tissue-level implants, the major component of marginal bone loss occurs immediately after implant placement, during soft tissue healing around the transmucosal portion. In this initial phase, so the question becomes, which is the determining, the most relevant etiologic factors common to both implant systems, bone-level and tissue-level implants? The answer is the biologic width establishment, which has recently been renamed supracrestal tissue height, and more recently, supracrestal tissue adhesion, for the presence of hemidesmosomes. And this is the best and more recent definition. And you can see similarities and differences between the natural tooth and implant. For example, you can observe the different disposition and organization of collagen fiber above the fibers above the bone crest. And 2 histologic studies in humans measured the biologic width around implants. The first study by Tomasi calculated the biologic width to range between 1.8 and 3.5 millimeters. Keep this range in mind over the course of my presentation. From a clinical point of view, this is a space between 2 and 3 millimeters. And it is relevant to know that supracrestal tissue height formation is completely formed in 8 weeks, within 2 months. And the supracrestal tissue adhesion establishment is determined by the physical contact between the transmucosal component of the implant and the vertical mucosal thickness. From a clinical point of view, after crestal incision and buccal flap detachment, it is important to measure mucosal thickness with a periodontal probe, for example, in order to distinguish a thin mucosa from a thick mucosa. Why? The explanation. A very important histologic concept. During biologic width establishments, at sites where ridge mucosa was thin, less than or equal to 2 millimeters, prior to prosthetic abutment connection, wound healing consistently included marginal bone resorption. This means that a thin mucosa sacrifices crestal bone apically to allow appropriate biologic width establishment. Appropriate, meaning a vertical space between 2 and 3 millimeters. But a thin mucosa is insufficient in terms of soft tissue thickness. Therefore, crestal bone must be sacrificed apically to recreate this space. The confirmation of this concept also in this very recent prospective clinical trial. The study evaluates marginal bone resorption occurring around tissue-level implants during supracrestal tissue height establishment and before prosthetic loading. You see, X-rays were taken at implant placement and 3 and 5 months after implant placement and before crown delivery. The conclusion of this study, again, during supracrestal tissue adhesion formation around transmucosal components, implants exhibit greater marginal bone resorption at sites with thin mucosa prior to crown delivery. This is the key word. Prior to means before crown delivery. And what happens to transmucosal implants after crown delivery and implant loading? The answer in this study by Homlei Wang. Let's see the graph. A significant greater bone remodeling occurs in thin mucosa before crown delivery and implant loading, but only in this initial phase. Nevertheless, after 1 year of implant loading, no difference of marginal bone loss was noted between thin and thick phenotypes, thin and thick mucosa. Basically, other factors, such as prosthetic and infective factors, are more important than mucosal thickness on marginal bone stability over time. For this reason, we shall analyze prosthetic factors, and we know that multiple abutment connection disconnections determine the disruption of the perimetral mucosal seal with possible bacterial contamination. The consequence is that multiple abutment connections significantly determine affected marginal bone changes, increased marginal bone loss. So we should minimize abutment connection disconnections during healing abutment connection, impression taking, and functional and aesthetic trains. This is a clinical rule. A positive relationship exists between excess cement and peri-implant diseases, both mucositis and peri-implantitis, especially with non-resorbable cements. So we should adopt screw retain prosthesis, bone in single and multiple implants. This radiographic study by Katafuki suggested that a relationship exists between perimplantitis and emergence angle and profile. An emergence angle greater than 30 degrees is a significant risk indicator for bone-level implants, but not for tissue-level implants. And subcrestal implant placement decreases this angle. This is a positive factor. A convex profile represents an additional risk for bone-level implants, but once again, not for tissue-level implants. The top image presents an excellent profile, concave. The middle image, a good profile, a straight profile. And the bottom image, a poor profile for hard and soft tissue. However, these factors, angle and profile, are supported by very limited evidence. On the other hand, however, in this first article published in the Journal of Dental Research, it was demonstrated that the key factor to limit marginal bone loss is prosthetic abutment height, calculated as the distance from implant platform to the apical edge of the crown. Let's see the two red arrows. In this study, an inverse relationship between abutment height and marginal bone loss was found. This means that the shorter the abutment, the greater the marginal bone loss around multiple implants splinted under the same screw-retained prosthesis. An interesting goal of this study was to calculate the optimal distance from the bone crest to the crown to limit marginal bone loss. This ideal distance was calculated to be at least 2 millimeters. An additional improvement to this new concept has been provided in this article, in which our group demonstrated that the shorter the abutment, the greater the marginal bone loss, also around cement retained crowns. And second, abutment height benefits are maximized by platform switching rather than non-platform switching implants. As demonstrated in this study, where two different implant systems were compared: Screwvent without the platform switching design and iris implants with the platform switching design. So we should adopt long abutments and a platform switching design. And in these recent years, the concept of the abutment height has been supported in many articles by independent authors. The conclusion of this meta-analysis is that longer abutments for bone-level implants appear to be a favorable treatment option for minimizing early marginal bone loss. However, in recent prospective studies have suggested that also vertical mucosal thickness must be considered in order to limit marginal bone loss. The soft tissue thickness protects osseointegration process from bacteria, and the biologic width, so renamed supracrestal tissue adhesion, ranges between 1.8 and 3.5 millimeters. We say, from a clinical point of view, a vertical space between 2 and 3 millimeters. And so let's see these two different scenarios proposed by Linkevicius. In presence of a thick vertical soft tissue, a limited amount of marginal bone loss was described, whilst in presence of thin vertical soft tissue, less than or equal to 2 millimeters, a greater marginal bone loss, a significantly greater marginal bone loss, was described after 1 year of implant loading. The consequent question is basically prosthetic abutment height and vertical mucosal thickness express the same concept. the biologic with establishment, for which a vertical space between 2 and 3 millimeters is required around the implant neck. But the fundamental question is what relationship exists between mucosal thickness and prosthetic abutment height. Vervaeke suggests that abutment height is simply determined by mucosal thickness, as abutment is adapted to site-specific mucosal thickness, as seen in this X-ray, in this clinical case, where mucosal thickness and abutment height are coincident, are causally the same. But in other clinical cases, they are not. Because, for example, a thick mucosa can be pushed apically by short abutments and crown placement. So this is the first clinical study to evaluate the simultaneous effect of abutment height and mucosal thickness on marginal bone loss. This evaluation was performed up to 12 months of implant loading. The two clinical variables utilized in this study, we adopted abutments of 3 millimeters and abutments of 1 millimeter in presence of both thin and thick mucosa. So we have created 4 different subgroups: patients with thin mucosa and long and short abutments, and patients with thick mucosa and, once again, 1 millimeter short and 3 millimeter long abutments. And the outcomes in this graph: platform switched implants placed at crestal level and restored with short abutments of 1 millimeter presented greater marginal bone loss than identical implants restored with long abutments of 3 millimeters, irrespective of peri-implant mucosal thickness. This is the issue. And these results have been confirmed in this by this longer 18-month investigation with greater patient sampling. And our results are in disagreement with Linkevicius' studies, but in close agreement with this article by Blanco, in which 3 millimeter long abutments better preserve crestal bone than 1 millimeter long abutments in presence of a thick mucosa. But, however, the use of a 3 millimeter long abutment in thin mucosa determines an aesthetic nightmare, an aesthetic complication, of course. And in order to avoid these aesthetic complications, implants can be placed subcrestally, allowing us to move the crown margin more apically and not visible while maintaining a long prosthetic abutment. Moreover, subcrestal implant placement provides an additional advantage, a functional and biologic advantage. And for this reason, a premise, I open a parenthesis. It is important to distinguish and also to measure separately bone loss and bone resorption, because bone loss represents the bone resorption occurring apically to the implant platform, leaving part of treated implant surface exposed to the oral cavity. This is the true bone loss. In this situation, peri-implantitis can start. However, bone remodeling represents the bone resorption occurring coronally to the implant platform. Therefore, treated implant surface remains in deep contact with the bone. This is a protective bone, and this bone can also support the soft tissue. You can observe in this situation, after 7 years loading, the second implant, the distal implant, subcrestal implant placement, platform switching, long prosthetic abutment, concave profile, no bone loss only bone remodeling. The adjacent implant, placed equicrestally with a short prosthetic abutment, you can see bone loss, minimal bone loss. But in this situation, the second implant, the mesial implant, perimplantitis, can really start. As demonstrated also in this study performed in bone level implants placed subcrestally. When implants are placed subcrestally, no exposure of a treated implant surface, and this is a potential preventive effect on future perimplantitis. An additional step was taken in this very recent study. Tissue-level implants were placed, adapting epicocoronal positioning of these implants to mucosal thickness. Based upon this more recent and detailed classification, it is possible to identify thick, medium, and thin mucosa using this new soft tissue probe, which is easier to read than a periodontal probe. So when mucosal thickness is less than 2.5 millimeters, we have a thin mucosa. If the soft tissue thickness is between 2.5 and 3.5 millimeters, we have a medium mucosa, and a thin mucosa is present when the soft tissue thickness is greater than 3.5 millimeters. In this study, we utilize these tissue-level implants. The machined 3 millimeter high transmucosal portion presents different colors to sync implants to different epicocoronal positions. In thin mucosa, implants were sunk 2 millimeters below the bone crest. In medium mucosa, implants were sunk 1 millimeter below, and in thick mucosa, implants were sunk at the level of the bone crest. And the outcomes in terms of bone loss, early exposure of treated surface resulted to be 0% in the first group, only 6% in the second group, where implants were sunk below the bone crest, and resulted to be 46% in the third group, where implants were placed at the level of the bone crest. So we can say that the adaptation of epicocoronal implant position to mucosal thickness may prevent unwanted exposure of rough implant surface. Subcrestal implant placement can effectively limit bone loss and therefore can prevent perimplantitis also with tissue-level implants, not only with bone-level implants. But from a clinical point of view, what are the implications of these findings where bone-level implants are utilized? For example, I normally use bone-level implants in 80% of my clinical case. I shall now describe a biologically oriented epicocoronal implant position. This is the last step of our initial decision tree, epicocoronal position, adapting implant to mucosal thickness. And we can adopt these rules also in aesthetic areas, of course, when a vertical GBR is not required. Let's see the first scenario, the best possible scenario. A thick mucosa is present. Our bone-level implant with a machined collar can be placed equicrestally, and a 3 millimeter long abutment can be adopted with a good aesthetic outcome, with a good emergence profile due to this deep soft tissue tunnel, and in presence of cement-retained crown, an easier excess cement removal is possible. You see the confirmation in these long-term evaluations, for examples. Medium mucosa. equicrestal implant placement with the machine collar is still possible, using only a 2 mm long abutment for an acceptable aesthetic outcome. It is a compromise solution. Another option is represented by 1 mm of 1 mm subcrestal implant placement. Again, with the machine collar, I prefer the machine collar when I place implant subcrestally. Of course, in this situation, a 3 mm long abutment can be utilized, and it guarantees an acceptable aesthetic outcome. The fully treated implant can be adopted, but I don't like this option. In thin mucosa, the dilemma regarding the use of long or short abutments exists when using equicrestal implants. The use of a short abutment, of course, permits a temporary good aesthetic outcome, but with subsequent greater marginal bone loss. Thus, we should reject this option. The use of a long abutment limits marginal bone loss, but is aesthetically questionable due to the supragingival location of the crown abutment margin, as previously seen. Well, zirconia abutment, yes, presents some structural limits, potentially resulting in abutment fractures, especially in posterior lateral areas in presence of strong occlusal loading. I don't like this solution. I prefer subcrestal implant placement combined with a long prosthetic abutment. This solution can be successfully adopted in daily practice because it is an easy, predictable, and minimally invasive treatment. As demonstrated in this prospective study, 3 mm long abutments work well in thin mucosa. With both solutions, machine collar or a fully treated implants, bone level implants, and also the demonstration in this other clinical study. So we can place implants subcrestally, of course. In presence of thin mucosa, 2 mm of subcrestal implant placement is contraindicated due to the proximity of anatomical structures. You see the nerve. In this scenario, vertical soft tissue thickening should be adopted using, for example, the tenting technique. And also, in aesthetic areas, we can utilize all these solutions. Subcrestal implant placement for these two missing lateral incisor, congenitally missing lateral incisor, two implants placed subcrestally, vertical soft tissue thickening with the connective tissue graft, and again, 3 mm long prosthetic abutments for a good aesthetic outcome, a long-term outcome. Well, the following conclusions can be drawn. The 10 golden rules of peri-implant mucosal bone stability. First, appropriate alveolar ridge width. Keep the three-dimensional implant position in mind. Second, well irrigated and efficient cutting drills. Third, torque insertion less than or equal to 50 Newton centimeters. 4. Platform switching internal conical connections or tissue level implants. 5. Machined implant collar surface. Machined is not polished. 6. Adapt epicocoronal implant position to mucosal thickness. Keep the classification of the soft tissue in mind. We have thick, medium, and thin mucosa. 7. Prosthetic abutment height greater than 2 mm. A 3 mm abutment height is an ideal abutment. 8. Concave prosthetic abutment shape. 9. Limit abutment connection disconnections. And 10. Screw retained restoration when possible. Thank you very much indeed for your kind attention.